Good morning, everyone, and welcome to today's webinar on male fertility with Dr. Stephen Lazarou from Boston Urology and Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you from Harvard around July or August. Additionally, we encourage you to submit questions to Dr. Lazarou using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, without further ado, I'd like to introduce today's speaker. Dr. Stephen Lazarou is board certified by the American Board of Urology. Dr. Lazarou completed his fellowship in male infertility and andrology at the Beth Israel Deaconess Medical Center, Harvard Medical School in Boston. He is a clinical instructor of urology at Harvard Medical School and the chief of andrology at Boston IVF. Dr. Lazarou specializes in treating all aspects of sexual and reproductive medicine. His expertise includes sperm retrievals, management of severe male factor infertility, as well as fertility preservation for men with cancer, vasectomies, and reversals. He also treats men with low testosterone symptoms and sexual dysfunction. He is also one of the few urologists in the U.S. trained in advanced microsurgery of the male reproductive system. Dr. Lazarou sees patients at his primary office, conveniently located in Wellesley Hills, Massachusetts, at Boston Urology. To optimize convenience for patients, he also sees patients in Boston and Waltham, Massachusetts. All right, let's get started. I'm going to now pass it over to Dr. Lazarou.
Thank you very much, Alyssa, and welcome everyone in joining me today in discussing male infertility. So our objectives today are to review the evaluation of the infertile male, to discuss management options, as well as surgical advances in male infertility treatment. So just briefly, for couples pursuing fertility, about 40% of the time there's a male factor contributing to the difficulties, in relatively equal proportion to female factor at 40% as well. And oftentimes there's a combination of male and female factors. Just a brief overview here, just to start, in terms of male reproductive anatomy. We know that the testicles make testosterone and they make sperm. The sperm are produced and mature, and then they go to the epididymis, which is above and behind the testicle, where they go through further maturation and processing. And then they pass through the vas deferens, which is over a foot long. And then the sperm are temporarily stored in this area, which is the ampulla of the vas. And then during sexual activity, it passes through the ejaculatory duct within the prostate, which sits below the bladder, and then out through the urethra. So when should a male be evaluated by a reproductive urologist? Well, for all men who have one or more abnormal semen analysis, including any abnormalities of the sperm concentration, motility, shape, and or the volume of the ejaculate, require an evaluation. Furthermore, if men have infection in the semen, such as white blood cells or blood in the semen, these two require evaluation. If there's a known history of male infertility risk factors, such as a history of chemotherapy, trauma, testicular swelling, torsion, or other factors, including family history of male infertility, those men definitely should have an evaluation as well. Furthermore, many men and couples question their fertility potential. They may decide that down the road they want to pursue fertility, but for other reasons, maybe professional pursuits, they want to make sure that their sperm quality is optimal, and or of course if there's any questions in general. A lot of men who have fertility issues suffer from difficulties with sexual performance, including erectile and ejaculatory difficulties. And even men who have normal semen analysis in the setting of recurrent pregnancy loss or unsuccessful ART or IVF attempts should have an evaluation by a reproductive urologist. So the standard evaluation is a detailed history and physical examination. And then the laboratory evaluation generally is for men to do at least 2 semen analyses. And standard evaluation also includes endocrine lab work, genetic tests where indicated, and ultrasound evaluation where appropriate and to provide additional information. So we generally use 12 months as the duration for when couples should pursue further workup. But certainly there are other factors that contribute to the timing. In other words, if there have been prior pregnancies with current or previous partner, if there are any other urologic evaluations or treatments or any other factors that might have developed since the time that they tried to start conceiving. Again, with sexual history, erectile dysfunction may be playing a role, diminished libido, ejaculatory difficulties, whether premature or delayed ejaculation, difficulties with achieving orgasm, and ejaculating intravaginally certainly need to be evaluated. Many men and couples use lubricants and spermicides, many of which may be deleterious to sperm. And then timing and frequency of intercourse is also very, very important. In terms of the medical history, any current or recent illnesses, high fevers within the last 3 months, COVID or otherwise, may play a role. And certainly you want to obtain information about medications, chemotherapy, radiation, and any history of any sexually transmitted diseases such as gonorrhea, chlamydia, or urinary tract infections or prostatitis. The surgical history for men is also extremely important. We do see men who have had a history of testicular cancer, so they may have a solitary testicle, but beyond that, they may also have had surgery called a retroperitoneal lymph node dissection, which can also impact their ability to orgasm and ejaculate. Many young men are also at risk for motor vehicle accidents, biking and straddle injuries to the perineum. And they may have had pelvic or inguinal surgery, scrotal surgery. I mentioned torsion as one. And in men of sort of middle age, commonly they are also dealing with enlarged prostate, BPH, and may have undergone transurethral resection of the prostate, which affects ejaculation, and even some of the other minimally invasive treatments for enlarged prostate may have an adverse impact on ejaculation and sexual performance. And then hernia repair, whether child or adult, a lot of times meshes are placed at the time of hernias, and these can create increased scarring or inflammation. Family history is very important. If there's any history of cystic fibrosis or other congenital issues, these are also important to consider and factor in terms of evaluation. So the physical exam is very, very important. So 2 main things we focus in on. First is the secondary sex characteristics, body hair, hair distribution, body habitus, and gynecomastia if there's any swelling of breast tissue. And then a focus on the genitourinary examination, examining the size, shape, consistency of the testicles and the location. Are they in the scrotum, or are they retracted higher up in the scrotum, or sometimes impalpable? You want to be able to palpate the vas deferens bilaterally, examine the epididymis, the structure around the testicle, to make sure there's no cysts or is not indurated or firm that might contain an adenoma or tender. And then presence of a varicocele and the presence of scars. A lot of men that we see don't even realize that they had pediatric surgery, and when you examine them, you say, oh, well, you might have an inguinal hernia repair or other surgery. And then a digital rectal exam where appropriate for men who may have urinary symptoms or a neurologic history, or over age 50, and you're screening for prostate cancer simultaneously. On the right here, this is a Prader orchiometer set that gives a general sense and guidance in terms of the testicular size. And again, we like the testicles to be at least 20 cc's or larger in terms of normal volume. So I have a low threshold for ordering scrotal ultrasounds. We palpate the testicles to make sure that there aren't any lumps or bumps, so to speak, and to palpate for enlarged veins. But an ultrasound is very helpful and provides detailed imaging within the testicle, which you can't palpate. And from time to time, we do find incidental or small tumors, abnormal blood flow, or infarcts. And certainly, we measure the size of the testicles very accurately, look for any cysts, and then again, looking for any enlarged veins or varicoceles, epididymal abnormalities, and enlarged fluid around the testicle. Other ultrasound studies that we utilize are renal ultrasounds or kidney ultrasounds, which you probably think is a far location away from the scrotum, but specifically in men who have congenital absence of the vas deferens, many of whom are carriers for cystic fibrosis. It's interesting to note that the embryological development of the ureter is closely associated with the vas deferens. So when there's an abnormality in one, it affects the other. So some of these individuals have kidneys in a different location in the abdomen or pelvic area, or are absent altogether. In terms of the transrectal ultrasound, which is an ultrasound of the prostate, the seminal vesicles, the ejaculatory ducts, we reserve that for men who have absent sperm or azoospermia, or who have severely diminished sperm concentration or motility, with otherwise normal sized testicles, normal FSH levels, and low volume ejaculate, and generally normal testosterone levels as well. So we're looking in this situation to see if there's any absence or swelling of the seminal vesicles, which produce the lion's share of the fluid for the ejaculate, and certainly if there's absence of the vas deferens, or we're looking for cysts. So in terms of the endocrine evaluation, we know that the GnRH is released by the hypothalamus and stimulates the pituitary gland. The pituitary then produces LH and FSH. The LH stimulates the Leydig cells, which are responsible for testosterone production. And the testosterone circulates in the bloodstream, but it also bathes the Sertoli cells, which is the sperm producing cells, in high concentrations, which are essential for sperm development. So FSH directly stimulates the Sertoli cells, but they work very closely in conjunction. And when testosterone levels are adequate, there's a negative feedback on the hypothalamus and the pituitary with regulation. I routinely check prolactin as well, because sometimes we do find men who have low LH and FSH and may have a pituitary adenoma or hyperprolactinemia. And thyroid, of course, is also important for metabolism, but impacts sperm production. So based on the World Health Organization, the most recent semen characteristics in 2021, the lowest 5th percentile is what's used for cutoff. We anticipate that the volume should be greater than 1.4 cc's, an adequate sperm concentration of about 16 million per cc or higher, total motility over 42%, and morphology over 4%. Now, it's important to realize that even men who have normal semen parameters may still be subfertile, and likewise, men who have lower than the threshold cutoff for normal semen parameters may be subfertile. So semen analysis gives us general information, but certainly important. There are multiple reasons why men can have oligospermia or low sperm concentrations. If there's been exposure to chemotherapy, radiation, heat, all of these may play a role adversely. If there's low testosterone, whether it's primary or problem with production of testosterone within the testicles, or secondary, again, from the pituitary standpoint. Anabolic steroid use, testosterone use, and we'll talk about that a little bit more, that creates negative feedback, and the LH and FSH production are decreased, and oftentimes that has a profoundly negative impact on sperm production while they're on it. Varicoceles and large veins play a role, various medications and toxins, and prior surgery, hernia repairs we talked about before. So asthenospermia, or diminished sperm motility, can also be affected by various exposures, chemotherapy, radiation, heat. Urinary tract infections, prostatitis, appear to be associated with increased inflammation and oxidation of semen. Certain medications, again, varicoceles, and some men can have partial obstruction of the ejaculatory duct rather than complete obstruction. So it's equivalent to having a 3-lane highway reduced to a 1-lane highway. So you get slowing of the sperm. Some are able to get through and squeak through, but they're oftentimes diminished in speed. And then artifactually, if there's delayed analysis of semen by the lab or drop off by the individual or cold exposure, that can also affect motility, especially if it's more than a couple of hours from the time of original production. And then various lubricants and spermicides may also have a role adversely. Teratospermia refers to the number of abnormally shaped sperm. The vast majority of sperm are abnormally shaped. Regrettably, even in 2025, this is poorly understood. There's a lot of back and forth in the reproductive community about how this is interpreted. There is variation based on the lab technician, and maybe with more artificial intelligence in future, standardizing that might provide a little bit more uniformity. But we do know that the majority of men with a low percentage of normally shaped sperm are still able to conceive naturally, with the caveat that there is a rare subtype of poor morphology where all the heads of the sperm are abnormal, what we call global Azoospermia. And those sperm tend not to be able to penetrate the egg and undergo proper acrosomal reaction, and oftentimes need ICSI. So in terms of genetic testing, and these are lab tests as well, these are indicated for men who have very low sperm concentrations, typically karyotype, looking for deletions, duplications, translocations. If the sperm concentration is less than about 5 million, certainly if men have an elevated FSH or small testicles, which really are indicative of primary spermatogenic failure. We recommend Y chromosome microdeletion for men who have sperm concentrations less than 1 million based on new AUA guidelines. And we're looking to see if there's any deletions in the AZF areas A, B, or C. And these can be inherited from father to son, but they can also be new mutations, de novo mutations. But they're important for counseling, and they also determine success rates for future sperm extraction. We do order sperm DNA testing commonly. We know that the sperm of infertile men generally have increased levels of DNA damage, which is oftentimes associated with impaired post-fertilization embryo cleavage. The DNA fragmentation score in infertile men is higher than those in fertile men, approximately 25 to about 10 to 15. And so we'll order these tests for couples who have had 2 or more recurrent pregnancy losses or failed IVF attempts. Low volume ejaculate, again, can be artifactual, and then there can be an incomplete semen collection, a short abstinence period, but again, could be due to blockages. There can be congenital abnormalities of the glands and ducts that produce and transport the fluid. Again, the testicles make all the sperm, but they actually only produce about 5% of the total fluid. The lion's share of the sample come from the prostate and the seminal vesicles. Prior urological surgery, diabetes, which may cause retrograde ejaculation or absence of emission, and then spinal cord injuries as well. And then urethral blockages. Many men have a history of strictures, trauma, or have had gonorrhea or chlamydia that can cause scarring of the urethra. And many of these men actually complain of difficulties with urination as well, slowing of the stream, incomplete emptying, pressure with urination, and post-void dribbling. So this is a series of diagrams here, just looking at the various types of obstruction. So again, the testicle makes sperm, goes through the vas deferens, and then around through the seminal vesicles, ampulla of the vasa, and through the prostate, and then out through the urethra. But in terms of a magnified image here, men can develop stones within the ejaculatory duct. We don't know why men get them. They do seem to occur more frequently in men as they age. Many men can develop cysts, which can cause narrowing or complete obstruction. And some men form stenosis, perhaps from urinary infections or scarring. So with resultant partial or sometimes complete obstruction. And as a result of this blockage, a lot of the men have not only low volume ejaculate, but they have acidic semen because the alkaline fluid of the seminal vesicles is not able to present. So they have acidic pH as well, and typically have absence or diminished fructose because fructose is also produced in terms of providing energy for the sperm. This here is a transrectal ultrasound image indicating an ejaculatory duct obstruction, a cyst right in the midline. And it's interesting to note that men who have midline cysts may oftentimes be carriers for cystic fibrosis. So we tend to think of absence of the vas deferens as the primary reason, which it is, for ordering cystic fibrosis testing or if there's family history. But sometimes we just see the cyst, and that's important that gene be tested for. In terms of all comers, there are non-surgical therapies that we offer for men with subfertility. Again, removing any toxins, aniline dyes associated with tar and petroleum industry, PCPs, smelly solvents, pesticides, avoiding chronic heat and radiation, not sitting in a hot tub on a daily basis. Sometimes men who are cooks or chefs get exposed to a lot of heat. Avoiding smoking, of course, treating any coexisting genitourinary infections, improving sexual performance, treating any pathology, prolactinomas, hyperprolactinemia, and tumors of the pituitary gland. In terms of antioxidants, the data is somewhat mixed on it, but I generally recommend multivitamins. There's little downside and there's upside, I believe, in terms of maintaining vitamin E, zinc, selenium. So oftentimes we'll recommend those in conjunction. And I don't think we can discount the need for a healthy diet, exercise, adequate sleep, stress management. All of these things play a role in terms of sperm quality. And we know that sperm generally is a biomarker for overall men's health. In terms of erectile dysfunction, most men with mild ED and situational ED, are responsive to medications like Viagra, Levitra, or Cialis, and they're safe from a sperm perspective. We do see a fair number of men who may have diabetes or vasculogenic ED, and they need more help, including medicated urethral suppositories, even vacuum devices, or penile injections to help them obtain an adequate erection for sexual performance. As well as in more advanced cases, we consider penile prosthesis. So we do see a fair number of men with premature ejaculation, which is defined with ejaculation occurring within 90 seconds of sexual activity. And a lot of these men are not able to ejaculate intravaginally. So oftentimes we'll offer SSRIs, not because they're clinically depressed, but because for a lot of the medications like Zoloft or Celexa or others, they cause a side effect of delayed ejaculation, and a lot of men find them helpful to use. Viagra, Levitra, Cialis also helpful, and topical lidocaine sprays help to reduce some of the sensitivity in the glands. And then sexual therapy is often very helpful. For men who have retrograde ejaculation, specifically diabetics, the sperm goes back into the bladder rather than out through the urethra. And oftentimes we use Sudafed to try to close the bladder neck to promote forward or antegrade ejaculation, or alkalinize the urine to try to reduce some of the acidity of the urine on the sperm, and then catheterize the bladder to extract sperm for assisted reproduction. We see a fair number of men who have had neurologic injuries or trauma, spinal cord injuries, and these men can and should be offered penile vibratory stimulation devices, which oftentimes work well. There are various devices on the market. There's also electroejaculation, where a probe can be placed in the rectal area under anesthesia and stimulated to induce ejaculate. But a lot of these men may have injury at the thoracic or T6 level or higher and are at risk for autonomic dysreflexia. So sometimes it requires several attempts to optimize the semen quality. But the issue is, for a lot of these men, they have to self-catheterize because they have neurogenic bladders, and a lot of them also have recurring urinary tract infections, which adds to the challenge because they may have some scarring. So sometimes, quite frankly, it's easier just to bypass the ejaculatory process and go directly to the testicle or epididymis and extract sperm. And almost always we can get high quality sperm for in vitro fertilization. So we touched on testosterone, and again, it's a critically important hormone. It's produced by the Leydig cells of the testicles and is very important for general men's health and for sperm production. It's the major androgen regulating sperm production. But it's interesting to note that up to 40% of men who present with subfertility have low testosterone, and clearly that can impact quality of life and sperm quality. And again, it can be either a primary issue with reduced testicular sperm production, or secondary, meaning higher up, for different reasons. Now, we know that a lot of men with low testosterone are indeed symptomatic. They may experience any or all of the following symptoms, such as reduced libido, reduced energy, vitality, well-being. They lose that spring in their step. A lot of men have loss of muscle mass, what we call sarcopenia. They may develop decreased bone mineral density, osteoporosis, and increased adiposity, especially visceral obesity around the abdominal area, and mood changes. A lot of men develop anxiety, depression, reduced ability to focus, concentration. They describe experiencing a brain fog. And as I mentioned before, sexual dysfunction is a big issue as well. So we do have a variety of therapies to optimize testosterone. Clomid is the one that we use the most. Obviously, Clomid is used in women to stimulate egg production, but we use it very commonly in men through a similar mechanism of action, but it basically induces the testosterone production within the testicles, and that oftentimes can improve any symptoms they may be experiencing, and while at one and the same time stimulating sperm production and maintaining fertility. We use aromatase inhibitors like anastrozole to block the aromatase enzyme. So as a result, we're shifting the testosterone estrogen ratio. So we're increasing the testosterone relative to the estrogen, and a lot of men feel better on that. And we use that a lot, for instance, in men who may have had an elevated body mass index or may be suffering from hot flashes or sweats from initial use of Clomid. And then gonadotropins such as HCG or HMG to really mimic LH and FSH in order to directly stimulate the testicles, especially if there are primary issues with the pituitary, and Clomid may not be a viable option for them. So there are a variety of gonadotoxins in the environment or that men are exposed to. Just a short list here. The most common are testosterone. And I know I mentioned that testosterone is an important hormone, but a lot of men use testosterone during reproductive age, and they don't realize that it actually has an adverse impact on sperm production. Many men who have an enlarged prostate are put on medications by their doctors called alpha blockers, which relax the prostate, but in so doing can reduce ejaculatory volume and therefore have an adverse impact on fertility. A lot of men are on finasteride to help shrink the prostate or to prevent hair loss. It does, block the conversion of testosterone to a more potent hormone called DHT, but a lot of these men can have reduced semen volume, sperm concentration, motility, or morphology, rarely, but primarily volume, count, and motility. Many men have had exposure to chemotherapeutic agents, especially alkylating agents, and radiation. And there's a lot of men who have had a history of substance abuse or maybe on chronic opiates or narcotics for back pain issues and so forth. And those too can lower testosterone. So in an ideal situation, it's best for men to be taking off these toxic agents and then recheck their semen parameters about 3 months later, because sperm production takes about 74 days typically. So unfortunately, men of reproductive age are at higher risk for certain cancers, testicular cancer, as well. It's been a tremendous point of success in terms of urologic oncology and men surviving. It's still a common condition that men deal with, whereby, again, they have removal of a testicle, but also exposure to chemotherapy, radiation, and surgery. Hodgkin's disease, lymphomas, bone and soft tissue sarcoma are not uncommon, as well as leukemia. It's critically important that all clinicians ensure that men, prior to beginning any chemotherapy or radiation. I think overall we're doing a better job in our clinical society, but there are still cases where men are not offered chemotherapy, and I think that's really an area that should be of primary importance for these men, because so many men survive nowadays and go on to live very fulfilling lives and can pursue fertility and should have that opportunity. So there are a variety of chemotherapeutic agents, alkylating agents, antimetabolites, vinca alkaloids, to name a few. And of course, the impact on sperm production is both agent and dose dependent. And again, all patients should bank sperm prior. In terms of guidelines, clinicians should inform patients undergoing chemotherapy and radiation to avoid pregnancy, natural pregnancy, for at least 12 months after completion of treatment, but 24 months is even better. If IVF is pursued, we generally recommend at least 18 months, because you're basically bypassing some of the checkpoint inhibitors, especially for IVF or ICSI. Varicoceles, as I mentioned before, these are very common. 20% of the male population has them. Most of them don't even know that they have them. They're generally palpable on examination. You don't necessarily need an ultrasound, but oftentimes an ultrasound is a useful adjunct. We measure the diameter of the veins, and anything more than 3 millimeters in size is considered to be clinically significant, and 40% of men present with them. And so the options for management include microsurgical repair, embolization of the varicoceles by interventional radiologists, and both of those have very similar outcomes, as well as observation, because other than occasionally causing discomfort in a minority of men, there really aren't any significant major health issues. But there are clear-cut indications for varicocele repair. If you have an adolescent that has a large varicocele and atrophy of the testicle, certainly that's a strong reason to repair. Some men have experience of pain. They may develop this dull, aching, intermittent discomfort, worse with standing or physical activity that typically improves when they recline. And then, of course, many men and couples that we see have already been trying to conceive for 12 months or more. And then one has to be sensitive to that and not say, okay, well, let's do a varicocele repair and wait 6 months or a year to see how the semen parameters improve. It's just not realistic and, quite frankly, not fair. However, there are some couples who want to treat the varicocele in parallel with assisted reproduction, or, of course, to try to see if they can improve their semen parameters in the longer term. And there is evidence that varicocele repairs may improve or maintain testosterone production, but that in and of itself is not an indication to do a varicocele repair, but rather a valuable secondary outcome. A major category is azoospermia. So probably 1% of the general male population has absent sperm in the ejaculate, but probably about 25% of men that we see in a male fertility clinic have them. And the category is primarily determined by the LH and FSH levels, which is to say that men, for instance, who have pre-testicular, meaning at the hypothalamic or pituitary level, oftentimes will have low LH and FSH. They have endocrine disorders, so they're hypo. They may have hyperprolactinemia. And a lot of the times this is due to congenital or chromosomal issues. But fortunately, a lot of times this is frequently correctable. Men who have testicular reasons for azoospermia have primary testicular failure. These are intrinsic disorders, and unfortunately, these are almost never reversible. Men may have undescended testes, torsion, mumps, toxic exposure, genetic disorders. And they mention here varicocele, although the new guidelines from the ASRM and AUA do not recommend surgical treatment of varicoceles in the setting of azoospermia. And then in terms of post-testicular, that basically breaks down to either problems with ejaculation, anejaculation or retrograde ejaculation, or true obstruction of the reproductive tract, whether it be post-vasectomy, congenital absence of the vas deferens, or obstructions in the epididymis or further downstream. But these are frequently correctable, and if not correctable, at least in terms of sperm extraction for IVF. Just touch on this a little bit for hypogonadotropic hypogonadism. When this is addressed with hormonal therapy, oftentimes in conjunction with endocrinologists, over 90% of the men do have resumption of sperm production within 3 to 6 months. Again, these are oftentimes congenital issues. One in particular is called Kalman syndrome. It's rare, but it's a genetic disorder carried on the X chromosome, and they have decreased GnRH and oftentimes a loss of sense of smell. Testosterone is very commonly used, and again, regrettably, a lot of men during reproductive age are on them. There's been a huge proliferation of anti-aging and low T centers throughout North America and the world. There's been a tenfold increase in the last couple of decades, and up to 1 in 6 men of reproductive years are exposed to it. Sadly, a lot of men are using testosterone without any clear indication other than wanting big muscles and improving body composition or at the gym. A quarter of these men haven't even had a testosterone level checked, and almost 40% of them don't even have follow-up. So we see a lot of these men in the clinic, and we really have to, start from the basics and build up from there. About a third of these men do not even meet testosterone therapy requirements. But on the flip side, like so many things, a lot of the men who need to be on testosterone, or at least to have normalized testosterone levels, are not receiving it. So we know that a lot of men on testosterone are azoospermic, close to 90%, again, because it creates negative feedback, that causes a decrease of GnRH, LH, and FSH, so the testicles shrink and there's decreased sperm production. Now, fortunately, in the absence of any other contributing factors, over 2/3 of these men have resumption of sperm production within about 6 months. If they're on topical T-gels, usually they recover within 3 to 6 months, but if they've been on high-dose injections, especially for a long period of time, it can take anywhere from as little as 3 months to up to a couple of years, and sometimes they remain azoospermic, and one can try a TESE procedure to try to extract sperm, but a lot of these men, unfortunately, are on really, really high doses of various anabolic steroids as well. So this is just a brief schematic here. So my approach is when we see men who have azoospermia or severe oligospermia, and we know they're on testosterone, we taper down the testosterone over a 1 month period and simultaneously start them on a medication like Clomid, check their blood work after about a month, making sure that they're feeling okay. And if we're not where we need to be biochemically, we'll oftentimes add in HCG to directly stimulate testosterone production within the testicle. And then we typically have them repeat a semen analysis at 2 to 3 months to see if there's any sperm presenting in the ejaculate. And then hopefully we can get to a point where there's adequate sperm. Unfortunately, a lot of men decide to jump back on testosterone during this process, so we'll encourage them to bank sperm so at least they can move forward with assisted reproduction, depending on their degree of commitment or compliance. Next slide here is about non-obstructive azoospermia. So again, these are individuals who have primary spermatogenic failure. They oftentimes have small or smaller testicles, not always, but usually smaller testicles, and elevated FSH levels. So this has really been a major step forward in success rates in terms of extracting sperm successfully for IVF or ICSI. Historically, we would just do a testicular biopsy, basically taking a little chunk of tissue and sending that off to the lab, and hopefully sperm was found. But with microdissection, what we call microTESE, we actually bivalve the testicle, so open it up to optimize the surface area and access, and then specifically looking for seminiferous tubules that are a little more plump and full, evaluate these intraoperatively for the presence of sperm. And then if sperm is found, it can be frozen and then thawed out at a later date for ICSI. And again, this is successful typically, about 60% of the time, depending on the clinical situation. And ultimately, in fact, despite the extensive surgical dissection, we remove a lot less tissue relative to the traditional approach, which reduces the risk of injury of the testicle in future hypogonadism. So in a perfect world, we'd love to see normal sperm production, but typically these men do not have that at all. What we're hoping for is hypospermatogenesis, where we're finding little pockets of sperm being produced. Alternatively, when we don't find sperm, pathology is either maturation arrest, where the sperm are being produced, but they're essentially stagnating or frozen at an immature phase where you don't have mature sperm. And then you have cases of Sertoli cell only, where you just have the base progenitor Sertoli cells, but no sperm being produced at all. As you can see here, no sperm compared to here, robust sperm being produced. We also consider microTESE not just for azoospermia, but for men who have cryptospermia, where they have rare motile or non-motile sperm in the ejaculate. And generally, we're able to find sperm through microTESE in over 70% of these men. One challenging scenario is in men who have absent sperm. They're azoospermic. The testicles may be of normal size, but their FSH levels are normal. So as I mentioned before, if the FSH level is elevated, that's pretty clear cut that there's a problem with production. So when the FSH is normal, we think, okay, this is likely an obstructive situation. And indeed it is the majority of the time. But even in men who have a normal FSH level, about 40% of them still may have problems with primary spermatogenic failure, and we may or may not find sperm in those situations. So it's important to, counsel patients with a sense of cautious optimism. In terms of fresh TESE, so these are testicular sperm extractions that are coordinated with the partner's oocyte retrieval. We primarily perform these during situations where men have Klinefelter syndrome, so they have typically high FSH and small testicles. And if we find sperm, it tends to be very, very small numbers, sometimes abnormally shaped. And so a lot of the times, because we're dealing with such small numbers, they may not even survive the freeze thaw process, which typically is not an issue for most men. So we use the sperm directly for ICSI. And the majority of these men, we do find sperm. Other reasons for fresh TESE include a single small testicle. If the couple has undergone, IVF or ICSI using prior frozen sperm, it wasn't successful, then we think by, optimizing sperm quality might provide additional benefit. And then in men and couples for whom there's elevated sperm DNA fragmentation, there's data indicating increased ART outcomes and pregnancy rates. So again, in terms of low volume azoospermia, we touched on the fact that this could be a collection issue or truly due to a low semen volume. Just briefly here, in terms of retrograde ejaculation, again, commonly we see that in men with diabetes where the sperm passed through the vas deferens, through the ampulla of the vas, but rather than the bladder neck closing, it remains open. So the semen go up into the bladder rather than out the urethra. And again, sometimes we'll use Sudafed or try to alkalinize, but direct sperm retrieval often works even better in terms of sperm quality. If there's no indication of retrograde ejaculation, diagnostic imaging is oftentimes helpful. We reviewed the transrectal ultrasound option to help determine if there's a blockage or obstruction there. And sometimes men do develop cysts, as I showed on a previous slide, right at the ejaculatory duct, right at the viriu. So sometimes under anesthesia, we can go inside endoscopically and unroof that ejaculatory duct cyst to allow for the obstruction to be relieved and to allow for antegrade ejaculation. The challenge with that is in some men, they can develop pain or scarring or even urinary tract infections. Just briefly, we do see a fair number of men who have congenital absence of the vas deferens and are carriers for cystic fibrosis. They oftentimes have low ejaculatory volume, absence of the vas deferens, normal testicular volume, acidic pH, absent fructose. So we check for cystic fibrosis, including the 5T allele, and the majority of them are positive for the mutation. As I mentioned before, sometimes they have abnormalities of the kidney. Vasectomies are very commonly performed in the United States, over 500,000 a year, but it's interesting to note that only 2% of men cryopreserve sperm prior to the procedure, but up to 6% of men choose to have children after vasectomy. The mean age of men is a little over 40 and women is 31 years of age. So in that situation, men do have options. We typically will offer an epididymal sperm extraction, which is really a straightforward office procedure to extract motile sperm. And if there's no sperm there, sometimes we'll take a little sample from the testicle, place in a little sperm wash media, and then the partner transports the specimen to the designated lab. And then the lab analyzes it and freezes it and then uses it subsequently for IVF. Men also have the option for reconstruction as necessary. So this here, just a few images here, percutaneous epididymal sperm aspiration. So under local, you can place a needle in, extract sperm. I personally prefer an open approach, which is directed with the microscope. I think you get better sperm numbers, both in terms of quantity and quality, and reduce the risk of trauma and bleeding. In terms of vasectomy reversal, I almost always will encourage couples to do a simultaneous sperm retrieval to give them the option to move forward with IVF, either concurrently or at a future date. And as surgeons, we need to keep in mind that we define success rates not just in terms of sperm presenting in the ejaculate post-reversal, which can take 3 months, 6 months, sometimes even up to a year, but ultimately to determine success based on pregnancy rate. So even under the best of circumstances with the reversal, there are certainly age-related changes in terms of pregnancy rate. So it's important to counsel couples about that, but certainly a reasonable option. So just to summarize here, I think the important take-home messages are that it's important to recognize that 40% of infertile couples will have a male factor contributing, that timely referral to a reproductive urologist can and does improve pregnancy outcomes and represents an opportunity for a men's health evaluation. Based on clear AUA and ASRM guidelines, men with one or more abnormal semen parameters or presumed male infertility should be evaluated by a male reproductive urologist for complete history and physical exam, as well as other directed tests. And other reasons for referral include IUI and IVF failures, clinically significant varicocele, idiopathic recurrent pregnancy loss, hypogonadism, and erectile and ejaculatory disorders. We know that men with infertility are at higher risk for comorbidities such as hormonal imbalances as well as metabolic disorders. And finally, male infertility may be the presenting manifestation of an underlying life-threatening condition such as testicular cancer or pituitary tumors. So that really summarizes the presentation today. I appreciate everyone's contribution today and participation, and wondering if anyone may have some questions.
Thank you, Dr. Lazarou. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the attendee control panel. Our first question is, are there any implications of long hot showers for men?
It's a good question. I think as a general rule, we recommend that men avoid chronic heat exposure. I think warm, hot baths where you're actually soaking in the tub consistently probably is worse than standing in long, hot showers. But generally for couples, I say, keep the shower time down to about 10, 15 minutes, and rather than very hot, keep it more tepid.
Great. The next question is, how do you treat an infertile man with significant elevated prolactin?
Yeah, so I routinely check prolactin, as I mentioned before, as part of the endocrine panel. And just like women, men can have hyperprolactinemia. And in men, that can manifest in a decrease in LH and FSH production, which in turn can lower testosterone levels. So it's very important that it be addressed because it's a very correctable factor. So when we find men who have an elevated prolactin, we make sure we check it twice to ensure that it's truly accurate. And if it is the case, then we order an MRI of the pituitary to look for any adenoma. And at that point, we'll typically recommend referral to an endocrinologist who will do further testing and typically start the patient on cabergoline or bromocriptine. And it's amazing how fast their testosterone levels improve within 3 to 6 months with corresponding improvement in semen parameters. So it's very treatable.
Thank you. The next question is, how do you manage a man who has had a vasectomy and is also taking testosterone?
Very good question. So I mentioned before, a lot of men who've had a vasectomy choose to have children, probably over 6%. But a lot of the men who've had a vasectomy feel, okay, I can go on testosterone now because it doesn't affect my fertility. So in that kind of situation, all the options available post-vasectomy remain the same in terms of doing a sperm retrieval or offering a vasectomy reversal in conjunction with a sperm retrieval. But it's very important that these individuals stop the testosterone. And I think in the interest of time, to simultaneously induce spermatogenesis with Clomid or the addition of HCG until their LH, FSH, and testosterone levels are normalized, because there's no point, it would be unfair to attempt a surgical procedure without everything in balance first. Once everything is in balance, typically within 3, maybe 6 months, then you can go ahead with sperm extraction or reversal.
Thank you. The next question is, how do you manage a patient who has recently been diagnosed with testicular cancer and is scheduled to proceed with chemotherapy and no sperm is found at the time of sperm banking.
Yeah. So that also is a difficult situation. So what we do know is the overwhelming majority of men at the time of initial diagnosis of cancer are subfertile. A lot of them do have oligospermia, especially those with testicular cancer. And we think there's a paracrine effect for that as well. But if truly they're azoospermic at the time of diagnosis, then um, these men generally need to have a radical orchiectomy or removal of the testicle. So it's very important that they be sent immediately to reproductive urologists. And we typically see these men within 24 hours. And in that kind of situation, what we do is we do a simultaneous orchiectomy where we remove the testicle and we do a microTESE at the same time. So we're not only removing the testicle, but we're exploring the testicular tubules, just like we do with the regular microTESE, and look at tissue on the same side of the testicular cancer, but also on the other testicle as well to extract sperm. And the majority of the time, we can find sperm. So then once they have sperm, it's sent to the lab for analysis and freezing, and they can and then should move forward with oncologic treatment, whether it be surgery, further surgery, chemotherapy, or radiation.
Great, that was our last question. So thank you, Dr. Lazarou, and thank you everyone for attending today's webinar on male fertility. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Or Dr. Lazarou, do you want to give out your email as well?
Sure. Please feel free to reach out to me anytime. I always have my cell with me, and you can email me directly at slazarou@bostonivf.com, and happy to answer any questions anytime. And
Great.
thank you very much.
So everyone, when you leave today's webinar, you will also receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Boston Urology, and Dr. Stephen Lazarou, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Lazarou.
Thank you very much.